Hi, good afternoon. Welcome and thank you for joining us today. My name is Lori Smentenka and I am the Executive Director of the National Consumer Voice for Quality Long-Term Care. Today's webinar is co-sponsored by the Consumer Voice, the Center for Medicare Advocacy, Justice and Aging, and the Long-Term Care Community Coalition, and is the first of a two-part program advocating for nursing home residents during the COVID-19 crisis. We, all of us advocates, have been watching the news reports, the horrible stories about how this virus is spreading through many nursing homes, the critical impact on residents, and we, like many of you, have been heavily engaged in advocating for the residents and the staff around this issue. Next slide, please, Libby. So we decided to come together and have this webinar, and we are going to be discussing today national advocacy issues, including steps that have been taken by CMS over the last several weeks and what it's meaning for residents. We're also going to be talking about select advocacy recommendations that we've all been working on together and share some ideas that we would encourage you to pursue as well. I'm going to just give some housekeeping for you today. Note that all of the lines will be muted during the presentation. We are recording the webinar, and a link to the slides along with the recording will be emailed out and posted on our various websites after the call. A link to the slides is also available in the chat box that's part of your control panel. If you do have questions, you can put them in the question box on your control panel, and we will get to as many of them as we can at the end of the presentations today. Next slide, please. So we're very glad to have a stellar lineup of presenters today to talk about the various issues. We have Toby Edelman, who is a senior policy attorney from the Center for Medicare Advocacy, Eric Carlson, directing attorney from Justice and Aging, Richard Mollett, executive director of the Long-Term Care Community Coalition, and Robin Grant, who is the Director of Public Policy and Advocacy from the National Consumer Voice for Quality Long-Term Care. Next slide, please, Libby. And with that, I am going to turn it over to Toby to get us started with the presentation. Toby?
Okay, thank you very much, Lori. Next slide, please. The nursing facilities, as we all know, are at the very center of the coronavirus pandemic. It seems like years ago, but actually it was less than two months ago that the Life Care Center at Kirkland, Washington became the site where we first heard about the coronavirus. Residents, staff, and visitors all became ill, and many died. Like nearly 2 out of 3 nursing homes nationwide, the Life Care Center at Kirkland had been cited with an infection control deficiency at its last annual survey. In April 2019, there were 4 problems with infection control. The facility wasn't doing infection control during wound care. It didn't use personal protective equipment with residents who were in isolation rooms. The ventilation system in the laundry room was not working, and there had been 2 outbreaks of influenza affecting residents and staff, and hand hygiene was not being done. So these 4 deficiencies, 4 problems in infection control led to the deficiency. But like more than 99% of infection control deficiencies that are cited nationwide, it was cited at a no harm level. And we know that unless it's combined, a no harm deficiency is combined with some harm or jeopardy deficiencies, there is no penalty. There's almost never a penalty for no harm deficiencies. On March 16th, 2 federal surveyors conducted an on-site survey at the facility, and they cited 3 immediate jeopardy deficiencies: failure to identify and manage residents who are sick, failure to notify the state of the increased rate of respiratory infections, and failure to have an available physician when the medical director himself became sick. CMS is imposing a per-day civil money penalty of over $600,000 for the period February 12th through March 27th. Next slide, please. We know that all people in congregate settings are at high risk, but nursing home residents are at tremendous risk from this virus because they're generally older and they are medically fragile. They have many health conditions that put them at tremendous risk. Some reports so far have indicated that 1/4 of the deaths are of residents, quarter of the deaths in this country, but we think that that's probably an undercounted number. We know some countries are not counting residents at all in their death tolls. The CDC says 15 to 30% of residents may die. And I saw a report from Medical Directors Association saying that the mortality rate might be as high as 1/3 of all nursing home residents. Just a frightening statement. This morning, McKnight's Long-Term Care News reported on the results of a poll. It's not a scientific poll, but 631 people responded. And this is some of what they said. 1 in 6 respondents reported that they had a resident or a worker who had died from COVID-19. 2/3 had a staff member call in sick or quit, and more than 83% were using homemade or reused personal protective equipment. They just don't have the equipment they need. Next slide, please. Problems that we've seen in nursing homes for many, many years are just made worse by the pandemic. The staffing shortages, which are pervasive in this industry, are worse now. Many staff members are calling in sick. They're unable to work. For the past several weeks and now into the foreseeable future, CMS is doing only a couple of types of surveys. And only then if the surveyors actually have protective equipment available to them. First, they said they would do complaints and facility-reported incidents that are triaged as immediate jeopardy. We have seen no information on whether any of these surveys are occurring at all. But the second, very relevant to us today, is the infection control deficiencies. CMS said they would do infection control deficiencies in facilities where there was a large outbreak of COVID in the community. On April 2nd, CMS reported the results of an unidentified number of infection control surveys that they had conducted during the week of March 30th. They found that 36% of facilities with infection control surveys did not do proper hand washing, and 25% did not use the PPE correctly. And then they said, quote, both of these are long-standing infection control measures that all nursing homes are expected to follow per federal regulation, close quote. So infection control deficiencies are the #1 deficiency in the country, 2 out of 3 facilities. And the #1 issue in infection control is hand washing. And here are facilities in the middle of pandemic, more than 1/3 of them still not doing proper hand washing. Next slide, please. One of the most significant issues we are facing, and is fundamental to everything else we can talk about, is the lack of information. The federal government is not releasing and probably doesn't have information about which facilities have COVID-19 positive residents and staff, how many are sick, how many have died. There's no federal mandate on facilities to report to the state, and not all states are requiring facilities to report to them, although day by day, more and more states are requiring reporting. In my view, CMS has authority under the law to require facilities to report, and it has authority to require states to collect that information. But CMS's position about the pandemic is, quote, that it should be, quote, locally executed, state managed, and federally supported, close quote. As a result of not getting solid information, the national and state media are trying to compile reports of cases and deaths. And from what we're seeing in the media, these numbers are growing exponentially. On March 23rd, CMS had said maybe 143 facilities had infections. A couple of days later, it was up to 400. And now we know it is many, many thousands. Next slide, please. Without good information, states cannot target additional personal protective equipment and staff to facilities that are in greatest need. An American Healthcare Association agreed on April 13th, saying facilities should be reporting to states so that states could help. And we know that residents and families are very fearful about what is going on in nursing homes, especially since visitors have been banned by CMS since March. So it's a month that people have not been able to go in and see their relatives. Next slide, please. We know some states are doing a better job than others. Some states are actually collecting and publicly sharing facility-specific information about infections and deaths. Of course, the ability to track COVID-19 is based on the ability to get tests, and tests are still in very, very short supply. but some states are trying to do a better job and having facilities report. Some states are establishing COVID-19 only facilities in vacated facilities, not doing a lot of movement back and forth of residents, which we know is dangerous. And some states are doing a better job at including residents and families in any transfer and discharge decisions that become necessary to cohort residents. Next slide, please. Going forward, we of course need to stay focused on what we can do now to make what is just a totally horrendous situation better for residents and families to the extent possible. We've got to try to make sure that they have the tests, the equipment, and enough staff. That is essential. But I think we also need to start thinking about what needs to change in our healthcare system when this immediate crisis is over. The CDC issued a morbidity and mortality report about the Kirkland facility, and it identified a couple of problems: poor infection control practices and staff working in multiple facilities. As I said, 2/3 of facilities have infection control deficiencies, and almost every one is called no harm. We need to treat regulatory requirements as important for protecting residents' health and safety, not as burdens on facilities that should be alleviated to the extent possible. We need to cite deficiencies better, call them what they really are, harm and jeopardy, and take appropriate enforcement action. With respect to the second issue about staffing, the concern was that staff, according to the CDC, were going from facility to facility. Now, some of the staff doing that are therapists, we know that, but a lot of the workers who are going from one facility to another are aides. And many of them do that because they have to work 2 full-time jobs. Their minimum wage salaries are not enough to support an individual, let alone a family. So we need to do a better job making sure people have a living wage when they have a job. And we also need to ensure that every worker has paid sick leave. Many aides have come to work sick because if they don't work, they don't get paid. And if you are earning $9, $10 an hour, you don't have any kind of cushion to fall back on if you're unpaid for a couple of weeks of sick leave. So we have to do better. And I think we need to start thinking about those changes that we need to fight for going forward, even as we do everything we can to make the situation better for residents now. Next slide, please. What we want to do today and at next week's webinar is share what we know about the federal requirements and the waivers. Now, the guidance is changing rapidly. Every day things are changing, but we will tell you what we know as of today, our best information as accurately as possible. We want to talk about CMS's recommendations and guidance, discuss advocacy at the federal and state levels, and we want to hear from you. Next slide, please. I'm going to speak very, very briefly about CMS and Congress. At the federal level, 3 things are going on. There's expansion of coverage, increased reimbursement, and I will talk about those very briefly. And then there's also waiver of longstanding requirements of participation. Next slide, please. One change made to Medicare very early on was a waiver of the requirement that a patient be an inpatient in the hospital for 3 consecutive days as a prerequisite to getting Medicare coverage in a skilled nursing facility. So under the rules now, with this waiver, people can be in the hospital as an inpatient for 1 day or 2 days. They can be in observation status. They can even come directly from the community. The point was to free up acute care beds for people who needed those beds. But this is a change that we think would be wonderful as a permanent change. But for now, anybody who meets the requirements and needs skilled nursing care in a skilled nursing facility, that means either skilled nursing services 7 days a week, therapy 5 days a week, or a combination of the 2, and other requirements, physician orders, things like that, people can get coverage. The second change to Medicare coverage was an extension beyond 100 days. Right now, people can only get a maximum of 100 days, although on average they get about 27. They can get 100, and then in order to start a new benefit period, people have to be out of the nursing home for 60 days, out of the hospital for that same 60-day period, then go back to the hospital for at least 3 consecutive days as an inpatient, then go to a nursing home. That requirement appears to be waived. Now, there's some inconsistency and ambiguity in the different forms this guidance has been presented by CMS, but we think CMS is saying that the benefit period can be extended if the need for skilled care is the result of COVID-19. Whatever that's supposed to mean, seems like every situation it would be applicable. Next slide, please. CMS is also increasing the use of telehealth for therapists, social workers, and physicians. And I just before this webinar began, saw that Seema Verma is saying maybe that's the kind of change we should keep permanently. That's one of the things that they're going to consider. We'll push the 3-day inpatient stay, but looks like the telehealth is something CMS is very interested in. And CMS also expanded for nursing homes the authorization of nurse practitioners, physicians, assistants, and clinical nurse specialists to do things that in the past only the physician could do. Next slide, please. We're also seeing increased reimbursement to facilities. The proposed annual update to Medicare's skilled nursing facility reimbursement that went on view April 10th increased payments by 2.3%. It's about $784 million for next fiscal year. They're proposing this increase even though the Medicare Payment Advisory Commission, as it does every year, says skilled nursing facilities should not get an increase. MedPAC says that because it's reported for over the last decade in a row and more, facilities getting Medicare have had margins exceeding 10%, particularly the chains, very, very high margins for Medicare. MedPAC's view is do not give them an increase. CMS is proposing a $784 million increase. Next slide, please. CMS has also approved $51 billion in accelerated payments. The last thing I just wanted to mention on reimbursement is the stimulus fund. $30 billion of the $100 billion was being released. And in discussing this at one of the White House daily press conferences on coronavirus, the CMS administrator said that nursing homes are getting $1.5 billion, and she said, there are no strings attached, so the healthcare providers that are receiving these dollars can essentially spend that in any way that they see fit. I put the link here to Skilled Nursing News, which is a daily online news journal with a focus on finance. And he has in that article a link to the exact part in the 2-hour press conference where you can hear Administrator Verma make that comment. Now, the next day, some nursing home attorneys said, well, no, really, there are strings attached. It has to be COVID related in order to get the money. Again, what does that mean? Everything seems to be COVID related these days. But the administrator herself said there are no strings attached to this $1.5 billion. Next slide, please. There's something else happening at the state level that concerns me quite a bit. The New York State budget bill that was passed provides immunity from civil and criminal liability to healthcare facilities and healthcare professionals who provide care during the COVID-19 emergency. The bill says that resources and staffing shortages should not be considered willful or intentional criminal misconduct, gross negligence, reckless misconduct, or intentional infliction of harm. So there is immunity in New York now for nursing homes related to the COVID-19 crisis. USA Today reported earlier this week that the Florida Nursing Home Trade Association was also seeking immunity from the governor. No word on what the governor had said about that and what he would do. And I'm very concerned that other states will see that as a good idea. Next slide, please. We know most staff go to work every day to do the very best they can. Most people are there trying to provide good care to people. We know that. And we know that now, during the coronavirus crisis, staff, all the staff, the healthcare facilities, everybody are putting their lives on the line every day to take care of residents. And we absolutely need to honor and support them by trying to make sure that they have all the tests, all the equipment, and enough of them, enough staff to be as safe as possible as they try to provide care to the very frail elderly residents in the nursing homes. What I'm worried about is the unscrupulous owners and managers, and there are many of them in this industry. The combination of more money, fewer rules, less oversight, if any, and now possibly immunity from any kind of liability is very, very dangerous. And we've seen the devastating consequences when they run nursing homes. Next slide, please. So most of our discussion for the rest of today is to focus on what's going on in nursing homes, what's been waived, what remains, issues that we have identified so far that we think are of greatest concern. And also, just to note, the federal government has granted a lot of Medicaid waivers to states as well. So that is my presentation, and now I'm going to turn this over to Eric Carlson. Thanks, Lori.
Thanks, Toby. So let's talk about waivers. Next slide, please. And we'll start with waivers relating to the transfers. Next slide. First, talking about transfers within the facility. There's some regulations that deal with transfers within the facility, and CMS during this emergency has waived those regulations for, like you see the language here, for the sole purpose of separating COVID positive and COVID negative residents. So for those purposes, there's no longer a right of residents to share a room based on consent. There's no longer a right to receive notice before transfer within a facility, and there's no longer a right to refuse transfers within a facility under certain circumstances. You know, as we'll note through the presentation, just because it's waived doesn't mean that ombudsmen and residents and families shouldn't still speak up. But we should, in that advocacy, we should recognize that during this time, those regulations have been waived. Next slide, please. And then the very big topic is the waiver of transfer discharge requirements. This relates to transfers from one facility to another. So CMS has waived some portions of the transfer discharge regulations, but only in 3 situations, which are COVID specific. Essentially moving someone that is positive or suspected to be positive to a facility that is dedicated to care of people who are believed to be positive, or transferring people who are negative, as best we know, to a facility that's focused on the care of people who are not found to have the COVID infection, or slightly different angle here, transferring residents without symptoms for observation stay. Next slide, please. And in these cases, according to CMS, advance notice is not required. It's not that the entirety of the regulations are waived, but only the provision related to advance notice. And CMS points out that, and this is certainly something you would hope, that the new facility, that the second facility has clearly agreed to accept that person. When we were talking with CMS, they emphasized the purportedly limited nature of this. But next slide, please. It may only relate to a particular couple of provisions within the regulations, but it's a pretty important couple of provisions, because essentially no advance notice is being required. There's practicable notice, but under the regulations, evidently that would be provided after the person has been transferred. So not really a tremendous insight here by me, but after it's been noticed, after you've already been transferred, isn't particularly useful. Next slide, please. Also, in related matters, that CMS has waived some standards relating to the physical plant. The idea being, as we all know, that there have been efforts to create greater capacity and greater capacity quickly. And so because of that, there's waiver of physical plant requirements to create a nursing facility very quickly in places where there currently hasn't been a nursing facility. And then next slide, please. Also, within the facility itself, to create resident rooms, essentially, in places where there haven't been resident rooms. And CMS cites the common rooms of the nursing facility that ordinarily aren't used for residents, activity rooms, conference rooms, dining rooms, etc. Next slide, please. Just a a commentary on these transfer rules. What's missing here, and there's been advocacy on this. I think all of our organizations tend to put something forward much more polished and focused in the next couple of days. But what's missing are the quality of care standards. There may be facilities that are purportedly dedicated to care for people who are COVID positive, but are they up for it? Do they have the staffing? Do they have the training? Are they capable, as Toby mentioned, of dealing with this population related to infection prevention and control, et cetera? And what's also missing is some requirement to work with residents, to talk with them. Just because the regulations allow you, supposedly, to just move people without talking to them, doesn't mean that that's a good idea. And that CMS should address that, facilities should address that, and states should address that. And there are some states that have done better than others, but in general, all of us, the society, the system needs to address those issues much better than they've currently been addressed. Next slide, please. We're moving on to some other focuses of the waivers, some care provider standards. Next slide, please. And this is similar to the increasing physical capacity. There are problems in the system right now. There aren't enough beds, there's not enough capacity, there aren't enough staff members. And in response to that, for better, for worse, CMS has allowed for the waiver of nurse aid training requirements. So ordinarily, you can work as a nurse aide only if you complete 75 hours of training and pass a competency examination. And that's for working after your first 4 months. You can work during the first 4 months before you've knocked out the entirety of the 75 hours, for example, but you have to be enrolled in a program. For the purposes of this emergency, those requirements have been jettisoned, and what's remaining is the broader, more general requirement that the nurse aide be competent. However, that is demonstrated, and just to give you a sense of what that might mean, the American Healthcare Association put together an 8-hour online training as one potential way for a nurse aide to build up competency in order to provide care. Next slide, please. And then also in a couple other areas that Toby mentioned, there's a greater use of telehealth, ordinarily for obvious reasons, but for whatever reason, legitimate reasons, physicians have been required to make visits in person. That's waived for the duration of this emergency, and also there's an increased ability for the physician to delegate tasks to a physician assistant or a nurse practitioner. The waiver specifies that this care must still be provided under the physician's supervision. So the physician doesn't completely offload his or her responsibility, but the work is going to be done by something else, but the physician remains some supervisory responsibilities to ensure the quality of the work that's being done. Next slide, please. And then we've referenced this as well. Toby mentioned related to visitation. Next slide, please. Most people on this call probably are familiar with these changes because they were the first to be announced, that there aren't communal meals or other communal activities. The regulation relating to resident councils and the facility's obligation to encourage resident councils has been waived. Next slide, please. And then most prominently, visitation has been dramatically limited. Essentially, family members and friends aren't visiting except for so-called compassionate situations. And the CMS discussion of this mentions its compassionate situations, includes end-of-life situations. It's not limited to that necessarily, but it includes end-of-life situations without any exact specification as to when something is considered to be end of life. It's not the same as justifying hospice care, for example. It's much more fluid than that. As a practical matter, a lot of it's really being left with the discretion of the facility to determine when a compassionate situation visitation is appropriate. Next slide, please. There's few essential persons. It's the staff members who are providing care, and then the surveyors have access as well if they have, as Toby mentioned, the protective equipment, who don't have the right to visit, who are limited to these compassionate situations, their family and friends. It includes ombudsman program representatives who are now doing their job via telephone by and large, and other healthcare providers who are facility staff providing direct hands-on care on a day-to-day basis. Next slide, please. And when visits do take place, CMS mentions they should be limited to the residence room or a quote-unquote clean room, maybe in the front part of the facility, and not rocket science here, who's ever visiting has to take significant precautions, the personal protective equipment, hand hygiene, you're not hugging people, and for obvious reasons. Next slide, please. But what's important to note here is it shouldn't mean that the residents are just in a complete social quarantine. There are alternatives, and as a lot of us are discovering, if you don't see people in person, you got to amp up your telephone calls and video calls and whatnot. And CMS suggests those sort of programs and communications. There's limitations on this, but we need to push for more. Residents are going to need some help. Staff's going to have to help. Oftentimes there has to be enough equipment. Note that New Mexico authorized some state funds to purchase tablets for use in facilities. Next slide, please. And then there's language that's a little bit stronger relation to the ombudsman program, the resident's representative, the physician, and someone from protection and advocacy there. Again, it's a question of degree here, but the language about the facility's obligation to facilitate that contact is stronger in relationship to these specified people as opposed to, for example, family members and friends. Next slide, please. And then we'll close with a couple of other waivers. Next slide, please. Some requirements dealing with reporting by and large here. The submission of assessment data can be delayed now. The PASSAR screening, which screens for people who may have an intellectual disability, for example, and maybe belong in a setting other than a nursing facility. Those requirements are being waived as well. And then also significantly, what's waived are the facility's obligation to submit staffing data under the payment-based journal system, and that is a loss because that staffing data has been very helpful in identifying facilities that are better staffed or more poorly staffed. Next slide, please. And just in closing, to think about waivers, there's a danger when you talk about waivers, and facilities may fall into this, all of us may fall into this, oh, it's been waived, it's the law's waived, and there's a danger that it's just assumed that the regulations don't exist anymore. It's a free-for-all, and I also understand the surveyor presence is more limited than it would otherwise be. But for those of us who advocate on behalf of residents, that's not a reason we should buy into that. The waivers on paper are much more limited to that. Even those that are broader in the transfer discharge situation don't mean that that they swallow up every portion of the rules. And it's important for all of us who do this work to focus on the requirements that remain, which are a lot. The waivers seem like a lot, but they don't certainly swallow up the entire system. So with that, I will pass the control over to Richard to talk a little bit more about this guides that CMS has issued.
Eric, thanks very much. That was really informative. What I'm going to do now is I wanted to review some of the key actions and federal actions and policies that we've been hearing about and which we have identified. We're hearing about from ombudsmen and from families, et cetera. Next slide, please. What I thought I would do is just start with a really quick background, just to make sure. I know there are really varying levels of understanding, and we get a lot of phone calls from families and advocates for seniors, and it's not necessarily clear to them. And there's no reason why it should be, because these are things that we kind of expect to be happening in our system, and we're seeing, as Toby and Eric both spoke about, how the system is really failing so many people at this time. So just very briefly, the Centers for Medicare and Medicaid Services, CMS, that's the federal agency that oversees both nursing homes, hospitals, other healthcare providers, essentially anyone who receives, any provider type who receives either Medicare and or Medicaid funding, And then the state survey agencies, it's usually a Department of Health or Department of Public Health. Those are the agencies on the state level that are responsible generally for both making payments to the providers, but also, and from our perspective, most importantly, for overseeing care. And in this situation, specifically nursing home care. And their role is, at least on paper, is to be protecting residents and be protecting the public. And I'm going to talk a little bit about both the federal requirements and federal guidance, as well as the federal recommendations. And it's an important distinction, I think. The federal requirements and the guidance, which is what the feds put out, CMS puts out guidance that direct how those requirements, how the law essentially and the regulations are to be implemented. And those are mandatory in terms of the expectations that are laid out for both providers, the nursing homes here, and for the state inspectors, the state survey agencies. And then recommendations, which we've seen the feds come out with over the past month or so. Those are what the government has identified as being a good idea, but it's optional for both the states and for the nursing homes themselves. Next slide, please. So first, I was going to talk about some of the recommendations, and again, when I'm not capturing all of them here. Eric spoke about some as well, and there are certainly, there's a lot of fluidity to this. So new things come out, things change sometimes from day to day, and I would recommend keeping in touch with any of our organizations, visiting our websites. We try to update people as quickly as we can. But here, in terms of some of the recommendations that CMS is making, this is, again, recommendation. Most of the language in my slides comes directly from either the requirements or the recommendations that CMS has put out. So the CMS is saying that nursing homes should immediately ensure that they are complying with all CMS and CDC, Centers for Disease Control and Prevention, guidance related to infection control. Facilities should focus on adherence to appropriate hand hygiene as set forth by the CDC. You might recall Toby said earlier that we were told that based upon just the inspections going on around the country in March, that facilities, 1/3 of facilities were still not performing appropriate hand washing. And as Eric just said, this is not rocket science. There's a lot of talk about PPE and people having access to, people not having access to, et cetera. That's important, obviously valuable, as we recognize, as the federal government has recognized over the past month or so. At first, they were not recommending that people use protection over their mouths and over their nose. Now they are. But most importantly, what we're seeing is that this virus is spread through touching, through breathing on somebody, through and then inhaling that in your nose, et cetera. So using hand washing, using basic sanitation and hygiene, again, as Eric said, not rocket science, doesn't even require a lot of PPE. It's really just basic common sense. Don't sneeze on people. Wash your hands after you've helped someone with toileting. That kind of stuff that, again, we're unfortunately not seeing in a lot of places, but that is really so fundamental. So that's why I wanted to talk about some of these some of these recommendations, Second, state and local health departments should work together with long-term care facilities in their communities to determine and help address long-term care facility needs for both PPE and for COVID-19 tests. These are issues that I've been looking at some of the questions in the Q&A that people have been talking about. This is, of course, a concern. It's a concern that we've seen in our home state of New York and been hearing about from across the country, that there's no PPE. If facilities say they have PPE, then they're not being honest with the public or not being honest with their residents and families. We know that there are shortages. Everyone from the president on down to the governors discusses this. There's a shortage of testing. So it's, again, that to me gets back to the point of expecting and advocating for good hand hygiene, good general hygiene, and taking safeguards to ensure that people aren't sneezing and breathing, coughing on residents, et cetera. Next slide, please. Additional recommendations that CMS has made for nursing homes. Long-term care facilities should ensure all staff are using appropriate PPE when they are interacting with patients and residents to the extent PPE is available and per CDC guidance on conservation of PPE. I thought that this was important, and I'll just skip ahead to the fifth point. And again, this all comes from, at the bottom of this slide, this all comes almost directly, if not entirely directly, from the CMS recommendations. And the last one here is to avoid transmission within long-term care facilities. Facilities should use separate staffing teams for COVID-19 positive residents to the best of their ability and work with state and local leaders to designate separate facilities or units within a facility to separate COVID-19 negative residents from COVID-19 positive residents and individuals with unknown COVID-19 status. And these are things that we have been recommending our organizations since the beginning, since the Kirkland outbreak in Washington State over a month ago. And unfortunately, we haven't seen these implemented, but it's so important. We know that there is a shortage of PPE. We know that there's a shortage or an inability to test around the country, both in facilities and outside of facilities. In the absence of having those materials and in the absence of having that knowledge, it's so important that these recommendations be implemented, even though they don't carry the weight of a requirement. And CMS makes a lot of excuses for facilities to the extent available, per guidance on conservation of equipment, et cetera. As Eric was just saying, knowing that these are the recommendations, these are essentially the standards, the expectations, what is known good practices for facilities and practitioners to be implementing, that is what we should be advocating for, even if it doesn't carry necessarily the weight of law at this time. These are the expectations that we should have. Next slide, please. CMS also changed, I think Toby spoke about this a little bit, they changed the requirements for state surveys, i.e. inspections. Now, normally, as I think many of you know, states are required to survey all nursing homes in the state on an annual basis, and there's a permissible time span of between 9 and 15 months per facility. Not all states abide by that, but that's what they're supposed to be doing under their requirements, because states get paid to carry out the surveys to respond to residents and other complaints about care by the federal government, by CMS, and that's where the tie-in is here. So normally, the surveys are required to take place on an annual basis. On March 23rd, CMS issued a memo changing temporarily the federal requirements about the carrying out inspections. And Toby talked about this a little bit. Essentially, and they said it was only going to be for 3 weeks, but as I note at the end of the slide, and I actually learned this from Toby at a meeting that Seema Verma, the CMS administrator leader, had just for journalists a couple of days ago. They said that they're going to be continuing this policy and until it is communicated otherwise. So that policy is that they are only going to do very select surveys. They're not going to do the annual survey. They are not going to be responding to most complaints. Now we know, and I know I hear a lot of always frustration throughout my career from residents and families of ombudsmen that states don't do a good job, generally speaking, in the absence of a pandemic, of responding to complaints. So here we're seeing for now and for the foreseeable future that there'll even be less of an inclination to respond, unfortunately, to complaints about care. Now, what they are supposed to be doing is the states are supposed to be going in if the allegation rises to immediate jeopardy. Unfortunately, for instance, I was watching the press conference yesterday that the governor of New Jersey and the head of the Department of Health in New Jersey gave in response to, I'm sure you've heard about it, the facility in northern New Jersey where there were people whose bodies were being stored in a shed and essentially rotting. How awful that was, and it's gotten a lot of national news coverage. Well, the state. The head of the State Department of Health, the survey agency, said that over this time period, throughout the pandemic, they have received no immediate jeopardy complaints. So that defies credulity, because there is certainly immediate jeopardy going on. There are certainly complaints that would rise to that level. The problem that I wanted to highlight here is that the states do not do a good job of identifying immediate jeopardy. So if you are filing a complaint and you feel it is putting a resident or more than one resident in immediate jeopardy of his or her well-being, it's critical when you file that complaint with your Department of Health to make sure that they know that, to be very clear as to that is the case. Then the only other types of surveys that the state survey agencies are doing are the targeted infection control surveys. We have not heard a lot about them. Unfortunately, what we did hear, as Toby mentioned before, is that over a third of those inspections were finding, that facilities were not undertaking appropriate hand washing. Again, as Eric said, and as I said before, this is not brain surgery. It's really just taking care of basic hygiene. Next slide, please. I'm not going to go into this. I was going to talk a little bit about resident transfer and discharge, but Eric already went through this slide. Normally, just very quickly, residents have to be given 30 days notice for a facility-initiated discharge. They have to have the right to initiate an appeal within that time frame. And as Eric noted, those requirements have been waived. It's supposed to be, and CMS has told us this verbally, all of our groups, that it's supposed to be only related to it's only waived in regard to circumstances related to a COVID resident. As Toby said, that unfortunately is, and as Eric said as well, overly interpreted or too loosely interpreted by facilities. But that's important too. If your resident or residents with whom you're working are being transferred for other reasons, that is not appropriate. Next slide, please. And then lastly, I just wanted to mention that the Office for Civil Rights of the Department of Health and Human Services on the federal level issued a bulletin at the end of March, and they stated that people with disabilities should not be denied medical care on the basis of stereotypes, assessments of quality of life, or judgments about a person's relative quote-unquote worth based on the presence or absence of disabilities or age. Decisions by healthcare providers concerning whether an individual is a candidate for treatment should be based on an individualized assessment of that patient based on the best available objective medical evidence. And I thought this was so important because we are hearing, and I've actually personally experienced with my own family member, someone who was denied care for COVID-19 because they were older and they were overweight. And so we need to be really careful about that. And here the feds have reiterated that we cannot discriminate against them. Next slide, please. I'm going to end it there. Again, I welcome you to keep up with us or with any of the other groups. We're all doing our best to keep on top of this changing situation and to alerting people whenever we can. Thank you.
Okay, so I'm Robin Grant, and I'm going to talk about some of the advocacy that has been going on at the national level. As Lori has mentioned, and I think everybody has referred to, our groups, Center for Medicare Advocacy, Justice and Aging, Long-Term Care Community Coalition, and Consumer Voice work very closely together. So I want to talk to you and share with you what we have been doing while all of you have been advocating so fervently and assertively at the local and state level. And I want to let you know how grateful we are for all of your efforts and your hard work. So we've been advocating primarily with CMS and with Congress. So just in terms of CMS, starting with the guidance that was issued by CMS on March 4th, we've been communicating our concerns and what we're hearing about and observing on the ground to the Division of Nursing Homes that's directed by Evan Schulman. So we have sent emails to Evan at all times of day, and some of us have been sending them also late at night, voicing our concerns. We've been doing that on an ongoing basis. We've been meeting with Evan Schulman by phone along with his staff, and we've put our concerns into writing. So I have to say that so far we haven't been successful in achieving a lot of what we're trying to get, but I want to say that there are a couple of glimmers of hope. Next slide. So the first glimmer of hope is that we're starting to hear from CMS that there may be more transparency required in terms of reporting cases. We don't know what that's going to look like, since we haven't seen anything official yet, but I guess, as you say, we're cautiously optimistic. The second glimmer of hope is that there may be some movement related to doing something about communication between residents and families. And I don't mean, unfortunately, I don't mean lifting the ban on visitation, but we've been pushing for CMS to direct facilities to actively facilitate calls or video chats between residents and families on a regular basis, not to be passive, but to facilitate those calls. And we've also been pushing for CMS to use federal CMPs to assist nursing homes in purchasing technology such as tablets to make that communication possible or to improvement. And we think, fingers crossed, we think there may be the possibility of seeing some money from CMPs being used for that purpose. So stay tuned, and you'll hear it as soon as we do. Next slide, please. And then recently, with the dramatic spread of the virus and the escalation in the number of deaths, our group of advocates felt that we needed to go to the top of CMS. And so we're currently drafting a letter to CMS Administrator Seema Verma, requesting that CMS take more action in order to better protect nursing home residents. We're close to finishing that letter, and we will certainly make that letter public once it's been sent, which we anticipate should be next week. Next slide, please. So what are the problems that we have been identifying in these conversations, these letters, and these memos to CMS? We've conveyed a number of concerns, but among the major ones are the lack of knowledge and reporting from each facility about the number of COVID cases and the fatalities, about the staffing levels, about how much or maybe how little PPE is available, and whether the facility has testing kits. We've indicated how troubled we are that there is very little knowledge of what is happening in facilities. We get calls from reporters who say, so what's going on? And we have to say, we don't know. Since families can't go in, ombudsmen can't go in, and surveys, as Richard said, of any kind are either non-existent or have been cut way, way back. We've repeatedly brought up the issue of isolation of nursing home residents due to the restriction on visitation and the extreme anxiety that is absolutely heartbreaking of family members who have no idea how their loved one is doing. We've raised concerns about various aspects of COVID-only facilities. One of our concerns is that there appears to be the lack of any criteria whatsoever for what nursing homes can be designated as COVID only. So right now, there really isn't anything to stop, say, a one-star facility for being designated, or even a special focus facility. We're concerned about residents being moved out of one facility to another in order for the first facility to become a COVID-only facility, rather than approaching it in a way that doesn't require residents to be, so many residents to be moved in such a short period of time. And Eric talked about this. We're very concerned about the lack of advance notice of these transfers within the facility or between the facility. And we're hearing, again, heartbreaking stories. I think there was a case in Massachusetts where a transfer occurred from a facility, and the family members had no idea where their loved ones had been moved. So that is just unacceptable from our perspective. And we're also, we've been talking with CMS repeatedly about the fact that there continue to be discharges of residents to unsafe locations, like homeless shelters or motels. We've seen this problem certainly before COVID became an issue, but these discharges are now of extra concern and doubly unsafe, because when residents are sent, for instance, to a homeless shelter, they may be exposed to the virus, or they may expose other people to the virus. Next slide, please. So those are among the major issues that we've raised with CMS. But certainly CMS as a regulatory agency isn't always the right entity to take action. Or sometimes if it won't take action, we have to pursue another avenue, and that's advocating with Congress. So at the end of March, we talked with members of the House Ways and Means Committee about some of these concerns. We've developed some legislative proposals that we've shared with Senate Finance Committee and the House Ways and Means Committee. So we've been conveying many of the issues I just discussed, but we've also recommended a few additional areas. And you can see those here on the slide, that there be a full-time infection preventionist. Right now, the regulation, as it currently reads, is only part-time. That there be civil monetary penalties for infection control violations. And you heard Toby talk about this earlier. There needs to be 2 weeks of paid sick leave for nursing home employees. So we've been talking to various members of Congress about these, about trying to get these issues into some of the emergency stimulus packages, COVID relief packages that we're seeing. So to wrap up our legislative work, I do want to end with, again, a little glimmer of hope. Next slide, please. So there is some movement based on, initially on the House side, on a letter that a number of our organizations sent to the Hill, but we pointed out this issue about communication between residents and families, and that there needed to be funding for technology to facilities so we can have that communication. And so I'm really delighted to say that there has been a bill that's been introduced on both the House side and the Senate side. It's called the Access Act, and you can, too many words here, so you can see what it stands for. But the bill would provide grants to facilities for technology to help facilitate, like, virtual visits between residents and their loved ones. So stay tuned. We hope that maybe it'll be folded into a COVID relief package, or even possibly move on its own. So we're going to continue our national advocacy efforts, and we'll certainly keep you informed through our alerts. But I want to spend a little time now quickly covering some recommendations about steps that all of you at the state and local level can advocate for. It's really been difficult, I think, sometimes to know what to advocate for. Things change so quickly, and frankly, often there's simply no right answer, and it's really hard to know what to advocate for. So we've put together at Consumer Voice a set of recommendations to give you some ideas for what to advocate for. And we hope to be releasing that next week. These recommendations are based on the most current thinking, the best thinking we've been able to identify that's come from our 5 advocacy groups, with input, I have to say, from Dr. Charlene Harrington, who's a marvelous researcher. It's come from state advocates, some of whom are doing amazing work, including, of course, long-term care ombudsman, and some states are sort of leading the way also. So these recommendations are designed to be directed at state and federal government and legislators. So just a caveat, you see this funky isolation menu, which I actually found online. The concept here is just that when you see our set of recommendations, we're not saying that you should be doing absolutely everything there. That would be, just wouldn't be possible. And we are instead just saying select. Select from, think of it as a menu of recommendations. So you can select what you are able to do, what's right for your state, your community, your situation. But we want you to have a range of steps and actions to advocate for. So I'm going to quickly go through and highlight 5 of those recommendations. And again, you will be seeing the full set with a lot of detail next week. So next slide, please. So the first recommendation is to establish a state-level team that would assess, plan, and coordinate state activities that impact residents of long-term care facilities. We've seen a number of states that have broad COVID task force, and that's great, but we really think that we need something that is more specifically focused on long-term care facilities. And that team should include the state long-term care ombudsman, as well as representatives of the state survey agency, CDC, and so on. So some of the things that this team should do is to gather information. So for instance, getting daily reports from every facility about what's happening in terms of staffing, number of cases, fatalities, availability of PPE. This entity, this team should also coordinate to ensure that that PPE staffing test kits gets to where it needs to be, identifying kind of where the problems are, what facilities need the most help, and then providing helping to provide resources to those facilities. We think that someone from that team should be monitoring on site in facilities with COVID cases. And part of what that this daily monitoring of the team and on-site monitoring would do is to be able to raise an alarm when there start to be real problems in the facility and there's signs of distress. So that at that point, another recommendation we have is that a strike team could be sent in. And this team would do things like help with infection control, actually provide care if that's what's needing, staff training, other things. We've seen strike teams in Maryland. We understand they're in Florida and also in Ohio. So we're in the process of trying to learn more about those teams. But we think that they have a lot of the potential to sort of help and help sort of stop the spread and start turning things around. Okay, next slide, please. So the second recommendation has to do with, it is to establish those distinct COVID only facilities or units that you've heard folks talk about a little bit earlier. That idea of separation is really important, but we also need to have some criteria. I think I mentioned that just a little while ago. So we think that team that I just mentioned should be part of developing this criteria, or should be the ones developing the criteria, and that the criteria you can see on the slide should address staffing levels. There should be a 24-hour RN nurse, adequate PPE, private rooms, and some other recommendations as well, but those are the highlights of the criteria. Next slide, please. Third recommendation is transparency of information. We have to have data. We absolutely need to have COVID-related information, number of cases, number of COVID-related deaths, and the number of total deaths. We can't address the problem unless we know the scope of it and its impact, and that means we need daily reporting of this information, and it should be reported to residents, families, staff, state survey agency. State survey agency should report this up to CMS and CDC. We also need staffing information to know what's happening in the facility, so that information should be posted again daily, both inside the facility and at the facility entrance. And then, so we have full, public disclosure here, the state survey agency needs to make this information available online on a daily basis. Okay, next recommendation, please. Okay, we've certainly heard a lot and talked about it on this webinar as well, about the need for adequate PPE and testing. So I won't go into that anymore or elaborate, because I think we all understand the incredible importance of both testing and PPE, but there has to be adequate protection and testing available. And last slide, please. So the last recommendation is to support and protect residents during admission, transfer, and discharge. And this goes back to what Eric was talking about in terms of transfer discharge situations. I mean, we know that that the waivers are in place now for notice, but we can do better. We need to be advocating and pushing facility staff and the state surveyors and ombudsman to have a conversation before there's a move with a resident and their representative to talk about options and plans. We realize that sometimes these moves have to take place really quickly, but it's really hard to imagine that there isn't time for at least some kind of notice and some kind of preparation. We think that some kind of notice really needs to be given to residents and families. The ombudsman needs to be notified by the facility when there's going to be a transfer within the facility or to another facility. And ombudsman should be given at that point in time the names of the residents who are going to be moved and contact information. Because we know that ombudsman involvement through relocations can make that a better situation for residents. And we know that, we understand that there's this need to group and separate residents with and without the virus. But we need to be advocating for all other involuntary transfers or discharges to be stopped during this time period. I mean, these evictions are always difficult and can be traumatic and devastating for residents. But they are doubly so now when being discharged can place individuals at risk of getting or spreading the virus. Next slide. So just one word about emissions. We have all seen how this virus spreads like wildfire once it gets in the door. So the best way to protect residents is to keep it out if at all possible. So what might that look like? It could mean that nursing homes should not be forced to admit any individual being discharged from a hospital, which is what is happening in New York and California. So even if a resident, somebody coming in is COVID positive and the facility to date has no cases, they must admit that resident. And it means that facilities with no known or suspected COVID-19 outbreaks really should be barred from admitting or re-admitting anyone without having them be tested as found to be COVID negative or having been isolated for 14 days. We have to do whatever we can, to stop the spread. Next slide, please. Okay, I just want to say in closing, I know Consumer Voice and all the other organizations that have joined us today will continue to work to do our own advocacy at the national level. We want you to know that we're there to support and assist you in that work and the great work, I have to say, that you're doing at the state level. Now, I realize that some of these recommendations may be sort of in the weeds, but I want to end with something that isn't in the weeds and that each and every one of us can do. All of us can draw attention to the problems and the solutions that are needed to save resident lives. We can share that information with our legislators at the state, the national, local level, government officials, our political leaders, organizations that we work with or are even part of, our faith communities, everyone. So there has never been a greater need for a loud, unified consumer voice to implore those who are empowered to do something to address the needs of residents of long-term care facilities. So speak up and speak out. And we're going to give you the opportunity to do that today, right after the webinar, by sending out an action alert that will allow you to send a message to your legislators, to Seema Verma at CMS, and by golly, to the White House, telling them that action must be taken. And so your action has never been needed more, and we hope we can count on you. So with that, I will stop and turn it over for Q&A.
Great. Thank you to Toby, Eric, Richard, and Robin for excellent presentations. There's a lot of information, as you can see. There's a lot of needed advocacy. We can probably take just a couple questions at this point. I'd like to remind you about the webinar next week on Friday at the same time, 2 o'clock Eastern, where we'll focus on what's happening at the state level, advocacy activities, so that the best way to learn is from each other and to highlight what some of the best practices are that are happening, and we want to share some of those with you. So join us again next week. You had the opportunity to register for that when you also signed up for this webinar. Jocelyn's going to help me with questions in just a minute. Could you go to the next slide, please, Libby? Certainly you are free to contact any of us. There are our web addresses and email addresses. There are a number of questions related to whether or not a resident can leave the facility during this crisis if a family and resident decides that they want to take them home for the duration of the crisis. And what does that mean for their bed hold? What does it mean for if they're Medicaid eligible? What does that mean for their Medicaid eligibility? Do they have the right to return? I do know that a number of states have been relaxing their bed hold policies during this crisis. But do any of you want to address that issue while we're queuing up one or two other questions?
I mean, this is Eric. The short answer is, yeah, you can go home. So I think that's the one clear thing. And the bed hold, I think it's unlikely that anybody's going to be holding a bed during that time. But I note that some public health experts have advised people that they'd be better off at home than in a nursing facility. So it's something that's clearly a legitimate option for folks if they're able to make sure that the people have adequate attention outside of the nursing facility.
Thanks, Eric. And another question that was asked a couple times also was about assisted living facilities and other settings. So you're right, we did address this presentation on nursing homes. That's where certainly the CMS guidance has been focused, as well as some of the congressional action. We know that these problems are existing in assisted living and other settings as well. And that's really being addressed at the state level. There's not national or federal oversight at the assisted living or these other settings. And so that has certainly been an issue, but it is an area that we are extremely concerned about what's happening in those settings. Did anyone else want to make a comment about assisted living or any of the other settings? Okay, Jocelyn, maybe we can just take one or two questions before we have to close for the day. Do you have one that's queued up?
Sure. Yeah. Well, actually, one of the first questions was, which I think goes to Toby, was talking about, and I actually saw this mentioned more than once. People were asking for some clarification on whether or not facilities can be fined at all right now, and if not, what sort of protections there are right now for residents.
That's a really good question. I think, and I want my colleagues to correct me if I'm wrong, I think enforcement is suspended for now. They're not doing any per day civil money penalties or denial of payments for new admissions. So they are taking complaints, for example, that they do not triage as immediate jeopardy, and they're putting them in the system, presumably to get back to at some point when this crisis is over. But I think we can pretty much say that there is not much enforcement going on. And that's one of the serious concerns we have, because the non-compliance is so serious and residents are so vulnerable. Does anybody want to contradict that or add to that on the panel?
So this is Robin. I certainly don't want to contradict it.
Well, you can, of course.
No, my understanding is that I think what CMS said is that that the only enforcement that will take place right now is is for immediate jeopardy. So if they do go in, cite immediate jeopardy, then there would be some enforcement, which usually is the notice of 23-day termination, I believe. Yeah. So, but nothing else.
Everything else is in abeyance. There's something else I just wanted to say. We have so many people that have been participating, and as we plan next week, I think all of us would welcome any good examples of what's happening in your state. So if you have something to share that you would want, please let us know, because we're doing our best to find out what's happening, but we would like to hear of good examples. And if you have bad things, I think we want to know that too, so that we can have as much information for next week's webinar as possible.
Thank you. Jocelyn, is there another question?
Yeah, so this is a little bit broad. I'm trying to take several different questions that were asked a little bit separately, sort of about accepting people into facilities or not. But one person asked in regards to Medicare coverage, if a resident can't leave a rehab because there's a COVID positive case there, will Medicare continue to extend their coverage even if rehab is over? Which is a more specific part. But then there were also a few questions about what happens when people are trying to get into facilities, even if they're currently COVID negative. They can't necessarily prove that, they can't get tested. And where can then COVID positive patients go when nursing homes refuse to take them? So there were a lot of different questions that sort of spoke to what happens to people who might already be in the system So just trying to bring that all together if anyone wants to speak to that.
Well, there could be an extension of coverage if they can't leave because of COVID. So the benefit period could be extended. I would just say, when I hear rehab being over, that always worries me because we have litigation in our office, the Jimmo case that says Medicare pays for services in the skilled nursing facility and also home health and outpatient therapy if the professional nursing or professional therapy services are necessary to maintain function or to prevent or slow decline or deterioration, not just if people are expected to improve. And we're always hearing still, 7 years after the case was settled, and it was a nationwide class action, so it applies to everybody in the entire country and all of those settings. We're still hearing daily that people are plateaued and so Medicare won't cover anymore. So that's not true. And they might even be entitled to more therapy services, but they could extend the benefit period. That is true. That is true. I think the concern about where people go from the hospital is something that states are quite concerned about, and it's why they're trying to develop COVID-only facilities. There was a lot of backlash when New York said every facility has to admit anybody that the hospital sends. A lot of people said that's just not a good idea. It will spread COVID infection in places where it might not already be. So either sending people to long-term care hospitals or distinct part skilled nursing facilities, which are generally have a higher level of care. They have more nurses, more doctors, or these COVID-only facilities that are being developed in vacated facilities. There are a lot of nursing homes that were closed in Connecticut, for example, and they are being reopened now as COVID-only facilities. That would be a better place for people to go out of the hospital until it's determined whether they're COVID positive or not. And if they're there for 14 days and they're okay, then maybe they could go back to their own facility if they want to. It's a lot of complicated questions, and I think we'll get into this more next week when we hear from some of the state practices.
Mm-hmm. Just as a practical advice, it's always been difficult to force a nursing facility to admit
Right.
To admit anybody. That's always been true. I don't mean to be overly negative here, but people might have an argument that the facilities are being unlawfully discriminatory in refusing to admit, but as a practical matter, there's no way to file an ADA lawsuit and litigate it in 48 hours. So I think you are in the realm that Toby's talking about, the healthcare system struggling with it, making decisions, pushing and pulling.
Yeah, I agree.
Okay, thanks. Let's do one more question.
Laura, I identified one I think I can answer in 10 seconds, that there were a handful of questions dealing with what to do with the payments that people might get and whether those are countable as income or resources under Medicaid. There's a FAQ from April 13th that addresses it. Question 54, the short answer is no. Not countable as income and not considered as resources within the next 12 months.
Great, and those are the stimulus payments that you're talking about, right, Eric? Yeah.
Right.
Yeah, yeah.
Great.
Eric, can I just add to that? Sorry, it's Jocelyn. One of the questions referring to that actually noted that in, I guess, whatever state they were in, a corporation sent a letter to residents stating that they should not touch the money and that the Department of Human Services will likely require it to go to their facilities.
Yeah,
No.
yeah. I saw that. No.
No.
No, the money is the residents' money. It's not the facility's money.
Tell us where that is and if there's documentation about that, please.
Okay. Jocelyn, one more.
Sure. There were also a few questions about residents' right to currently leave their facilities. There were situations where people were saying facilities are not allowing individuals to leave, and then there are other facilities where if someone does leave, they're not letting them return. Even if they just go outside, they're not letting them go outside, out off of the facility grounds, I guess. They're not letting people come back in once they've left the building.
What to even respond?
Yeah.
Yeah, I'll take a swing at that. That I think that's hard. That I think the legal answer is, of course, people have a right to walk outside and go down the street, um, buy a gallon of milk and walk back. That's that's always been true, and there's no formal um, waiver of regulations that would affect that. But we know what the situation is, and we know we just spent an hour and a half talking about how to keep this infection out of facilities. And so that lawyerly answer is not the way I would present it if somebody asked me for advice. And yeah, it just, so I'm not a clinician, but my eyes are open, and so it's just it's bad news if somebody walks out, gets in someone's face, and then walks into the facility. And so I off the top of my head, I'd say I respect facilities' ability to try to get that under control, because it's legally it is law is more or less what I just said it is, but there's some real obvious practical problems there.
Mm-hmm. Certainly points up the need for facilities to have a place where people can go outside safely. You know, a courtyard, some sort of property, so that they're not stuck inside a building all the time. The idea that people would never get outside and feel the sun on their faces is a pretty frightening thought. I mean, possibly if somebody wants to go, of course, there's not enough staff, but a reasonable thing would be to try to, have a staff person walk with somebody, protect the person, just make sure the person isn't just wandering into a grocery store nearby and, just not maintaining social distance. So, there could be a way that people could get some fresh air. Seems like an important thing to try to make happen for them.
Great. Okay, we are past the amount of time we had said we were setting a time for, but obviously there are so many things that need to be talked about that we thought it worthwhile to extend a little while longer, but we are going to need to close for today. So I'd like to thank Toby, Eric, Richard, and Robin for their excellent presentations today. I'd like to thank Jocelyn and Libby for helping with the back end of the operations of the webinar today. Please join us next week. We will be talking about some of the state advocacy that is going on, which I know some of your questions were addressing some of those issues. And so it'll be very informative as well. Also, watch for additional information from all of our organizations jointly and individually. We are continuing to work on this literally on a nonstop basis. This is one of the, I think, crises of our time. And it is one that we are very concerned about and are continuing to advocate for. So thanks all of you for your attendance today, and we look forward to talking to you next week. Have a good rest of the day and stay safe, everyone.
Yeah, thanks so much.
Thank you.